Good afternoon. Myself, Dr. Avnish Kumar Jha. I am presenting topic Orthodontic Diagnosis. I am Associate Professor in Dental Institute, RIMS, Ranchi. This is very crucial topic for the various students. Orthodontic diagnosis deals with the recognition of various characteristics of the malocclusion. The following are the essential diagnostic aids. We all know that the body first is the case history, then clinical examination, making study model, taking certain essential radiograph like periapical radiograph, bite wing, panoramic facial photographs, so the first we start with the general case history and general examination. We record the patient detail, identification, communications, psychological benefit. It helps in the recall and referral. So second phase thing is the age, general and dental development to chronological age in determining the growth rate and stage of maturity. It also helps to indicate the growth spurts. As we know that in our body there is a different tissues and each tissue has a different time of maturity. We know that the lymphoid tissue matures at the age of 10 years, 200%, and then it goes to regression. Neural tissue mature 90% at the age of 6 years. And then it goes steady growth and completed till then general growth is a S-shaped and genital growth starts at the age of 12 to 14 years and reaches the peak at 20 years. Six, the patient six should be recorded in a case history. This is important in treatment planning as the timing of the growth events such as the growth spurt is different in males and females. Occupation, as there are occupation-induced diseases, helps in evaluation of the socio-economic status of the patient and parents. Address with telephone number is very essential to record the details. It helps us in the patient recall, future correspondence, to intimate appointments. Then references from where the patients who got referred to us, that is also very crucial information. And the chief complaint, there are two logical reasons for patients concerned about the ailment and occlusion of the teeth. Impaired in facial aesthetic that can lead to psychological problem and impaired function. Past medical history, it is difficult to get proper medical history, so we need to collect the informations from the patient like different syndromes, which occlusions, fetal alcohol syndrome, Pierre-Robin syndrome, Fletcher-Collins syndrome, synostosis syndromes. We know that the Fusion syndrome is an uncommon autosomal dominant craniofacial disorder characterized by the premature closure of the cranial bone suture, and the syndrome is due to mutation in the fibroblast growth factor 2 FGF2 gene. Clinical features include maxillary hypoplasia, short upper lip, widely spread eyes, shallow orbits, protruding eyeballs, short head, calcified styloid ligaments, maxillary hypoplasia, the dental arch width is reduced, crowding of maxillary teeth is a common two-thirds of fusion patient have been unilateral or bilateral crossbite. This is the clinical photographs of the fusion syndrome. Then the similarly is the fetal alcohol syndrome. It is a prenatal exposure to alcohol causes a spectrum of disorders. One of the most severe effect of drinking during pregnancy is fetal alcohol syndrome. So it should be avoided during the pregnancy time. Then Pierre-Robin syndrome is a condition present at the birth that is characterized by very small lower jaw. The tongue tends to fall back and downward, and there is a cleft soft plate. This is the Pierre-Robin syndromes, lateral cephalogram, radiograph. So these are the clinical features of Pierre-Robin syndrome. Then there is a Strickler syndrome, several genes which control direct collagen synthesis. The building of a complex substance by joining and interaction of the simpler material may cause a Strickler syndrome. This is Strickler syndrome, clinical photographs. Treacher-Collins syndrome, it is congenital syndrome. Both the maxilla and mandibles are underdeveloped. It is due to the result of generalized lack of mesenchymal tissues. These are pressure syndrome, photographs. So there are many syndrome, and the syndrome you will get the malocclusion. So identifying these things are very important. As we know that there is the effect of alcohol, similarly there is the effect of smoking. We know that the cigarette smoking by the mother is an etiological factor in the development of cleft lip and palate. This is a clinical photograph of cleft lip and palate. Infant posture from time to time investigation purpose to show that the poor postural condition can causes the malocclusion. How the infant posture in the womb also determine the future malocclusion after birth. Accident or trauma, it is probable that accidents are more significant factor in malocclusion than is frequently recognized. Syndrome which causes the retardation of the growth are Pierre-Robin syndrome, cleidocranial dysplasia, craniofacial dystosis, mandibular dystosis, Marfan syndrome, Down syndromes, syndrome which increases the growth, the gigantism, acromegaly, Scafie's disease, craniofacial dystosis, osteosis deformis, Paget disease, syndrome which causes supernumerary teeth. You will get in cleidocranial dysplasia, Gardner syndrome, syndrome which causes facial asymmetry, hemifacial microstomia, hemifacial hypertrophy, juvenile rheumatoid arthritis, Pierre-Robin syndrome, van der Waals syndrome, Esker syndrome, median cleft face syndrome, Metzger syndromes, syndrome causing missing teeth like hereditary ectodermal dysplasia, cleidocranial dysplasia. This is a clinical photograph of the cleidocranial dystosis. Congenital syphilis, as we all know that the mulberry, molar, and screwdriver shaped incisor we are seeing in the congenital syphilis, ragates, fissing and scarring of the corner of the mouth, frontal bossy and saddle nose, soft maxilla, high palatal arch. This is a clinical photograph of congenital syphilis. Teratogenes, a variety of causes exist for embryological defect, ranging from genetic disturbance to specific environment insult, chemical and other agents capable of producing embryological defect if given at the critical time are called teratogenes. These are teratogenes, and you will see that their effect, like the cigarette smoking effect in cleft lip and palate, ethyl alcohol in central midface deficiency. So these are teratogen which affect the different organs of the body. Other condition which one should ask about health problem during the case history is that establish the patient's socio-economical status, history of hospitalization, about immunization, about allergen and medications. Uh, One should check the following conditions of the patient like heart murmur, heart disease, rheumatic fever, sickle cell anemia, bleeding disorder, blood transformation, hepatitis, AIDS, HIV, tuberculosis, arthritis, cancer, tonsil, adenoid, sinus problem, radiation therapy, growth problem, attention deficit disorders. There is a lot of genetic influences also on the malocclusion. We know that the genetic influences on congenital deformities, facial asymmetry, macrodontia, oligodontia, tooth shape, cleft lip and palate, frenal dystonia, deep overbite, crowding. Past dental history should be noted. Family history should be noted. Patient's history is divided into three parts, basically prenatal, natal, and postnatal. The information about habits should include pencil biting, tongue biting, lip biting, tongue thrusting, mouth breathing, thumb sucking. Psychological examination of the patient motivation for seeking the orthodontic treatment can be classified as external or internal. Then comes to the clinical examination. We should know the height and weight of the patient to provide a physical growth and maturation of the patient, which may have dentofacial relation, nutritional status, gait of the patient, how the patient walks, posture of the patient, refer the way a personal abnormal posture can predispose to malocclusion due to alteration in maxillomandibular relation, body types, aesthetic, plethoric, athletic, body build. Body build of the patient is divided into ectomorphic, mesomorphic, endomorphic. Endomorphic patients are short and obese. Ectomorphic patients are tall and thin. Mesomorphic is average build. So the purpose of examination is to record the information about the frontal view, profile view, and functional analysis of the facial structure, which help us guideline during orthodontic therapy. Also to improve the aesthetic appearance of the face. In a frontal view, we take the note down the shape of the head, that is called cephalic, facial form, that is called facial index, facial proportion, facial symmetry, forehead examination, nose examination, lip examination, like interlabial gap, lip posture, tonicity, lip step, lip thickness, and height proportion. This is how we get the cephalic index. It is a maximum skull width divided into maximum skull length, and the values for the dolichocephalic, mesocephalic, brachycephalic are this is in this way the skull of the patient is classified. It is given by Martin and Seller by 1957. So these values you should remember if it lies on the 76 to 80.9, it is a mesocephalic. Facial index, it is calculated by morphologic facial height divided by bizygomatic width. So uroprospic, mesoprospic, and leptoprospic, how the face is divided. So this is a, you shall see that the uroprospic face, mesoprospic face, and leptoprospic face. Leptoprospic face is a narrow and long face. Uroprospic face is a broad and short face. Then the facial proportion, there is a transverse facial proportion and vertical facial proportion. If you divide the face in a upper one third, middle one third, and lower one third, and upper lip and lower lip is one third is to two, there is a ratio. The face is in a one in divided into five parts. In one is that called the vertical proportions. So if the ideally these proportions should be maintained, normally the interpupillary distance is 65 mm and 35 mm. The intercanthal distance is 30.3 and 30.6. Outer canthal is 9.8. Then we get the symmetry of the face, whether face is symmetrical or asymmetric face. First one is a symmetrical face, and second one is a asymmetric face. Structural classification of dentofacial asymmetry is like there is a dental asymmetry, skeletal asymmetry, muscular or soft tissue asymmetry, or functional asymmetry. This is how the symmetry from the lower mandible is noted by some mental view examination. Forehead examination, flat forehead, protruding forehead, or stiff forehead. Then there is a nose examination from the size of the nose, nostrils examination about the width of the nostrils, its patency of the nostrils. Leptorine nose, one profile view of leptorine nose and more nasal projection. Frontal view is narrow and has more nasal height. This is a mesorine nose and then laterine nose. These are different type of the noses you will get. Then one of the most important thing is the examination of the lip, whether the lip is a competent lip, incompetent lip, potentially incompetent lip, or inverted lip. Lip steps, how the lip, upper lip and lower lip closes to each other. There is a positive lip step, slight negative lip step, that is a normal, and marked negative lip step. Marked negative lip step you will see in a class 2 malocclusion. Positive lip step you will see in a class 3 malocclusion. So profile analysis, in a profile view, you have to analyze the facial profile of the patient, facial divergence of the patient, nasolabial angle, naso examination in profile, lip examination in profile, mentolabial sulcus, chin examination, maxilla-mandibular vertical projection, mandibular plane angle, visual treatment objectives, these are profile analysis. This is how we take the facial profile of the patient, 3 points, glabella, subnasal point, and chin. These 3 points are connected, and we assess the profile of the patient, whether it is straight, it is a concave, or it's a convex, straight profile, backward slanting profile, and forward slanting profiles. Facial, it may be straight, convex, and concave. Straight you will get in a class 1. Convex you will get in class 2, and concave you will get in class 3 malocclusion. Nasolabial angle, whether it is obtuse, it is a angle formed by the base of the nose and the upper lip. This suggests about the protection of the teeth. If it is acute, roots are procline. Your obtuse cases you will get in a class 2 division 2 malocclusion where the central incisors are retroclined. Nose examination with a straight nose or convex nose. And similarly, there is a lip examination that is a protrusive upper lower lip, protrusive lip method is to how the soft tissue analysis we will do. The mental-level surface is defined simply as the fold of the soft tissue between the lower lip and the chin. It may be great form and depth. It affects the lower incisor position and vertical height of the lower face. Upper lower incisor tend to result in a shallow mental-level sulcus and lack of lower lip. Deep mental-level sulcus is a common in a patient with the short faces and class 2 relation because the lower lip is averted against the upper incisor and lip reduction called a short lower lip. The patient with a long face has a tendency to have a flat mental-level sulcus because of the flattening of the mentalis muscle to attain the lip posture. The deep mental-level sulcus is a characteristic of hyperactive mentalis muscles. Similarly, this is a clinical photograph of mental-level sulcus, how the shallow mental-level sulcus looks, and how the deep mental-level sulcus looks. Deep mental-level sulcus you will get usually in class 2 and shallow mental-level you will see in class 3 cognitive mandible or procline lower incisors. Hyperactive mentalis muscles you will see in class 2 cases. Chin examination, protruding chin with the mental-level sulcus, normal chin and negative chin. Configuration of chin projection is determined by the two factors, the amount of bony projection and the amount of soft tissue overlap the bony projection. This is how the maxilla and mandible vertical proportions is noted in the profile view. Mandibular plane angle, how we measure the mandibular plane angle. Fang foot mandibular plane angle and lower border of the mandible. It suggests the clinical apnea. If it meets distal to the auricle, it is a low plane angle. If it is near the auricle, it will be average, or if you look front of the meet front of the auricle, it will be high plane angle, high clinical apnea. Visualized treatment objective is one of the method to see the treatment prognosis in the class 2 and mild class 3 cases where we put the patient's jaw in forward position and we assume how much the changes we can do by the myofunctional appliances. So there are some functional examination which is very important for the orthodontic diagnosis is the respiration, mastication, deglutition, centric relation, centric occlusion, maximum mouth opening, smile analysis, perioral muscle activity, temporomandibular joint examination, knowing the pain, sound, path of the closure. This is the breathing, how the examination of breathing is done by mirror test. Patient is advised to take the breath in front of the dental mirror and vapors is noted. Nasal respiration, observation of nostrils. Oral nasal respirations, allow muscles in inactive layers do not change with their sizes. This is how the deglutition is examined, how the phases of the proper speech is very important. We see that the S and Z sounds are produced by the lips. Anterior open bite and large gap between the patient is unable to produce S and Z. P and D difficult in irregularly incisor, especially in rival position of mandibular spider. In skeletal class 2 cases, F and G sound difficult to produce. Anterior open bite short jaw is very difficult to produce. So we should know the patient-centric occlusion, centric relation, how the that is harmony is there. Freeway space, the space between the teeth and when the mandible is at the rest position is usually 2 to 3 mm required as a freeway space or interocclusion clearance. Method is determined. We can determine the freeway space by phonetic method, command method, non-command method, and combined method. This is the how maximum mouth opening should be noted, deflection and deviations of the jaw in right and left wheelbarrow. Another one important examination is the smile analysis. Smile maze is designed by attorney to analyze the smile of the patient. Excessive maxillary incisors. This is the table which shows that the maxillary central incisors in male 1.9 mm, but for female it may be 3.40 mm. Mandibular incisors 1.23 mm and 0.4 mm. Excessive maxillary incisors shows due to the short upper lip filtrum height. Excessive vertical growth of maxilla can cause excessive incisor display, excessive crown height, and distort maxillary incisors. Inadequate incisor display you can see when there is a excessive upper lip filtrum height. Inadequate growth of maxilla may result in inadequate incisor, so inadequate crown height, flared maxillary incisor, high final attachments. Then the gingival visibility in the smile, which is also known as a gummy smile. Gummy smile you will get in cases of short filtrum, vertical maxillary access, excessive curtain on a smile, short incisal crown out, upright maxillary incisor, high frenal attachments, temporomandibular joint examination. TMJ examination is a routine part of the orthodontic diagnosis. We see the auscultation, lateral palpation of the TMJ and posterior palpitation. Then the lateral pterygoid by palpitation, temporalis muscle palpitation, masseter muscles palpitation to analyze the things. These are how we do the muscles examination. So the eighth component is the smile, how the lip line should be. It should be actually the good smile line is when your smile arc reproduces the lower lip curvature when the upper incisors, lateral, canine, and premolar curvature is parallel with the lower lip. It is a consonant smile and is a beautiful smile. Upper limb from various studies, how what should be the perfect relationship of the upper and lower upper lip length. In Dollystone suggests it should be 23.6 in male. In female, it is 20.1, but there are different studies which show different. But the value is in and around 22 for the male and for female it is 20. So this is the different lip positions, lip due to the lip length. You can see the change in the smile. So lip and smiles is one of the important factor for which the treatment patient asks the treatment and your results, what the treatment planning will be. That also how the smile, what type of the smile. So understanding the smile is a very important thing. Okay. So I will conclude my lecture today. The modern orthodontic include a series of different types of treatment requiring precise diagnostic techniques in order to produce a positive outcome. The careful, complete extraoral examination of the patient will guide in proper treatment plan. Thank you. These are the references. Thank you. Thank you for giving me time.